Okay, so tonight I would like to welcome Dr. Sean Meers. Sean has received his doctorate of physical therapy from Ohio State. He specializes in management of orthopedic neck and back pain, focusing on quality of movement, function, and ability to live a normal lifestyle with or without pain. Um, in 2018, Sean authored clinical practice guidelines for chronic pain. So I can't imagine a better person to come and talk to us tonight about chronic pain, something that a majority of the folks in our exercises medicine deal with. So welcome, Sean. We're happy to have you here, and the floor is yours.
In my clinical practice, I had noticed that a lot of patients, they were it was a wide variety of patients I was working with. Patients could span from 14 or 15 years old all the way up into their 90s. And so early on, I thought to myself, okay, so in physical therapy, we learn structure and pain usually goes hand in hand. So if someone has a disc bulge or someone has degenerative disc disease, you can expect these symptoms. You would expect referred pain over onto the side of their back. You might expect some sort of nerve irritation that might go down into their leg. But what was odd early on in my clinical practice was that I was seeing patients that were 14, 15, 16 years old, and they were, for some reason, having chronic pain for 5, 6, 7 years, or even most of their life. And so then I would look at their imaging and I would see that overall they'd have normal imaging. But then I'd look at individuals that were in their 90s that had severe, borderline on the verge of having spine surgery type of imaging, and they had very mild to moderate symptoms. And so I started to ask myself, from what I learned in physical therapy school to actually working in the clinic as a clinician, I started to wonder, why is this? Why is there individuals that are so young that are dealing with such severe symptoms, but then there's 90-year-olds that have severe symptoms and their symptoms are so mild or moderate, as if it's not bothering them as much. And then looking at different patients, I started to wonder, why are certain individuals doing better in physical therapy and why are certain individuals doing worse? And so I started to question, what might improve someone's outcomes in physical therapy versus someone that might not do too well in physical therapy. And then looking around my clinic at the spine center at the time, I would see there was 4 other providers there. I would see difference in physical therapy treatment. In addition to that, I would see certain doctors recommending certain treatments to individuals that was much different than what maybe I would expect. And so I started to question, what is going on with individuals that have chronic pain? What is actually the right way that we should be treating them and helping them? So that is what led me to want to research this topic more. I wanted to dive in and research this more and see what's in the literature and what are overall our clinical practice guidelines for treating people that have chronic pain. So this is a family friend. His name's Don. He's 90 years old. He's a former Navy veteran, and he also lived independently at home.
Sean,
yes.
Your slides are not up.
Oh.
So if you just want to share your screen.
Oh, it's not on. Oh, sorry about that.
Yeah, no problem. I didn't know if that was just more background before this slide deck was needed to.
Oh, gotcha. Yeah, so you can see it now.
Yes, good to go. And you may want to hit the presentation button down there at the bottom just to make the slides look. There we go. Perfect.
Okay, good. All right, sorry about that. I didn't know that. So yeah, this is Don. So now you can actually see Don. But anyway, so talking to him, it was Thanksgiving and I was sitting at the table, and at that time I'd already been working for 6 months at the spine center, working with a wide variety of patients, different ages. And I just was so curious to hear about, for one, Don's story, but 2, I wanted to know about his pains as well. And so I was sitting there and I asked Don, do you have any pain? And he said, no. And I said, really? Are you joking? And he said, no, I've never felt pain at all in my life. And so unfortunately, a year later, he fell on some ice and he ended up breaking his hip, and he ended up having a total hip replacement. 2 days later, I went to go visit him in the hospital, and I asked him how he was doing, and he said he was doing well. And I asked him, are you taking anything for pain? And he said, no. And I said, what, do you not have any pain? And he said, I have no pain 2 days after a hip replacement. So it was just like a very eye-opening moment, how structure doesn't really correlate with pain. And it was really a moment that I wanted to learn more about chronic pain and why are certain patients I'm seeing in the clinic doing well, not doing well? Why do they have severe pain or not that severe pain? This leads me to the next topic of adversity and resilience. So at some point in our life, we will hit some sort of adversity. We will experience maybe a motor vehicle accident. We might we might experience a broken arm at some point. We might likely have some back pain. We might even lose a loved one. And there are certain ways that people might deal with adversity. Over time, they could become victims where someone else is responsible. It was because of that motor vehicle accident 20 years ago that this is why my back is so painful. And most often individuals that feel like they are victims, they focus on the past very much and not so much on the present or future. Catastrophizers are the what ifs. They're obsessed about the future. They will say, okay, my knee has been bugging me. I'm probably going to have a knee replacement in the next month or two. Or they might catastrophize about their back pain and say, I might have to be bedridden. I might have to quit work and file for disability. And who's going to take care of my family? So just very obsessed with what could happen in the future. And then the perpetual patients, you take on that sick role. It's also known as learned helplessness, and you start to seek out passive treatments. You see doctor after doctor after doctor. You get more and more opinions, and you get more and more frustrated too about all the different opinions, and perhaps you're not getting better as well. So resilient people that experience adversity and they take ownership of the present. Resilient people, they take responsibility for the outcomes made by their decisions. So if someone determines that they have some back pain and maybe they've been lazy the past year or so because of COVID and they need to start getting back into the gym again, those are resilient people that will make good, positive actions in order to change the outcomes of their life. Individuals that blame something from 20 years ago and they can't move on from it, they can't get past it, oftentimes do not get better. And that is the unfortunate truth that I've seen in my PT experience, is that if you constantly are focused on the past, if you're constantly worried about the future, if you're seeing provider after provider after provider, you've done 3 courses of PT and now you're seeing me for your 4th course, it does concern me a little bit that this individual is not going to get better unless certain actions are taken. And sometimes the patient has to be accepting of what I'm trying to discuss today as well. And so sometimes patients aren't ready, they're not ready yet, and that's okay. Maybe at some point they will come around. Maybe they need to seek out like a pain psychologist as well to help them get to that point. So the question is, what is pain, since we're talking about chronic pain? And I hope to answer that for you today. So what is pain? Is it a warning signal? Does it indicate some sort of tissue damage has occurred? Can pain be detected or found via X-ray or MRI or CT scan? Where does pain come from? And what do you do about it when you do experience pain? So one of the leading researchers in our field, Dr. Mosley, he actually describes pain as a highly complex, unpleasant feeling in our body that makes us want to change makes us want to stop and change our behavior. So essentially, it's a protective mechanism. If we have our hand on a hot stove that's burning our hand, we want to know and feel that type of pain and that unpleasant feeling. We want the behavior, the action will be, we're going to remove our hand from that hot stove. But what happens if we burn our hand 5 weeks ago and we're still sensing pain? To a degree, pain is protective, but at the same time, it can also cause misfiring. It can also be over-exaggerated. And that's usually the definition of chronic pain, is that our nervous system is on high alert when it should not be on high alert. So so to kind of go through the whole pain experience, there's alert sensors throughout our whole body. They're called the eyes of our brain. These are known as nociceptor receptors. These nerves then connect to a spine neuron. If the brain senses credible danger or threat, such as you just ran over a ground nest, a beehive nest, a bunch of bees are attacking you and stinging you, it's good to know that. And so the brain is going to send more feedback to it from that spinal neuron, and you're going to change your action or your behavior. If the brain is sensing something that is not a credible danger, it's going to decrease the sensitivity of that spine neuron. It's important to understand, and this is the newer information that's coming out about pain science, is that only alert or danger information can come into the brain. Only pain is produced within the brain. And it's important to understand that pain is a highly complex phenomenon, as well as it involves multiple areas of the brain, as I'll show you. Pain can be turned on or amplified by anything that provides the brain with evidence of danger or harm. So if someone every year hurts their back shoveling snow, and they're walking outside and they see some 20-year-old shoveling snow, and they might make a comment saying, "That hurts my back," just watching that individual do that activity. And so what I usually will say is things that nerves that fire together will wire together. So if you have a constant or frequent episode of some sort of pain experience, oftentimes even just thinking about that can elicit pain. And that is purely in the brain. There's no structural changes that are occurring in the periphery. So the power of the mind. So this just goes to show you that there's several areas in the brain that is involved in pain processing. In the center is the thalamus. That's the relay center for the brain, and it can relay pain information to the cerebral cortex, to where you actually are processing that pain and trying to understand that pain. Also, the amygdala, which is just a little bit south from the thalamus, it can anticipate pain. It works to anticipate pain and helps you with reacting to perceived threats. So just goes to show you that the back pain that we have, it's not always related to that structure down, far into your back. Oftentimes it's very much interconnected with your brain. And because the brain is processing all of these different experiences that you've had in the past, you're collecting this information and you're trying to register it and figure out what to do with this information. So the way that we pretty much classify pain is if it's acute or chronic. So if there has been tissue damage, we consider that more acute, and we base it off time. So if the pain has been going on less than 3 months, then we would consider that acute pain. You treat that by just going through the normal healing process. You do rest, ice, compression, elevation, and also relative rest. Unfortunately, 20% of patients that develop some sort of acute pain, it can persist and then it can become chronic. So, and I give an example of a bee stinging you, and over time, that sensation should go away, that pain sensation. But what happens if it does not? So chronic pain is any pain that's been going on longer than 3 months. They say this because by that time, all the tissue that was irritated or damaged should be healed. It's just normal tissue healing time, typically is 3 months. So if pain persists after 3 months, then you're starting to think that this is more of a chronic issue. It's less of a tissue issue and it's more of a nerve issue. The nervous system is on high alert. Pain does not indicate the level of tissue damage anymore. Oftentimes, these individuals that have chronic pain, there's a lot of stress that's going on in their life. They might develop some mood disorders like depression and anxiety. They might be seeking disability now. They might have lost their job. There might be financial and social hardships that are occurring too in their life. overall, the focus of our treatment is to restore their quality of life, and that's by promoting movement for individuals that have chronic pain. So why should we care about chronic pain? For one, it affects a lot of us. So 20% of the population has chronic pain. We, as a country, spend a lot of money on it. So we spend over $500 billion per year via our healthcare for treating chronic pain. There is a significant increase in back surgeries throughout a period of 10 years, 137% increase. There is a significant increase in epidural steroid injections as well for back pain. Chronic pain takes a significant toll on the individual and the family. I ran into my realtor not too long ago, and I remember her husband had chronic back pain. I tried to help him for a short period of time, and he ended up going and hearing from the realtor about this. She said that he ended up talking to a pain psychologist, and his pain just went away just by talking about it. And it took a toll on her and his relationship very much, that she felt like it was him, her, and his back pain, 3 people in the room at one time. So just it can ruin marriages even at times. It can ruin your family. You're not taking trips to Disney anymore. So when we look at different miracle treatments, so, soaking in some Epsom salt or using the inversion table, really patients might come in and ask about this stuff. And I just say it's a way to manage pain. It's not going to cure it. It's not going to necessarily take it away forever, but it might be a temporary thing. And truly, I'm in support of anything that helps you manage your pain better, to live a better quality of life. So, but I remember thinking years ago, how does this little brace on the side of your knee take away any sort of sciatica sensation? And so just, kind of be mindful that a lot of money is made each year for treating or curing chronic pain. And there's truly no cure for chronic pain, unfortunately, right now. The question is, how do we manage it? To just go further about the complexity of pain, there's 400 nerves in the body. So it's not like 1 or 2 nerves that are, innervating our feet and toes. There's a lot of nerves in our periphery. 40% of the population has a disc bulge on MRI, and they have no symptoms. So just because you have a disc bulge does not mean that you're going to have some sort of sciatica or any sort of like radicular symptoms going down your leg. At the age of 20 is when usually imaging will start detecting degenerative changes in your spine. So just because you have that fancy name degenerative disc disease does not necessarily mean that you've got some sort of disease that's going on in your spine. It's actually just normal spine aging, not any different from any other joint likely in your body that is a weight-bearing joint. 40% of the population has rotator cuff tears, and they have no pain. And then 35% of college basketball players have severe, significant knee abnormalities on MRI, but they have no pain. So again, just going with the idea that structure doesn't necessarily equal the amount of a change in structure doesn't mean that you're going to have a linear degree of pain with that change. Chronic pain, oftentimes, you might see some structural issues with chronic pain. If you look at some hands that there's some nodules that are developing, you can expect that there's some significant osteoarthritis, or maybe even the patient has some rheumatoid arthritis. Usually the pain is widespread. Usually the exam will be pretty normal. You're not going to see a whole lot of neurologic symptoms with it. And that's why you go see the doctor first too. You want to make sure that there's no significant structural issue that, like cancer, for instance, that might be causing these symptoms. You want to rule out that there's no significant, like something called cauda equina that might not be repairable if you don't catch it in time. For example, if you lose control of your bowels and bladder. So it's good to see your doctor and let them kind of guide you on what to do next. Just FYI. With chronic pain, there's oftentimes flare-ups. They can have mood disturbances like anxiety and depression. Usually they might have some brain fog. They might be fatigued. They might have some sleep disturbances. And oftentimes they're very sensitive to stimulation and stressors. such as just by touching them, that can elicit severe pain. When we treat these individuals that have chronic pain, we look at the biopsychosocial model. So we understand that we're treating the human. We're not necessarily just treating like that low back area. It's more than just nociceptive input. We're looking at the whole human. So we're not just looking at the biology. We're looking at the social structure. Also, is there any other factors from an emotional standpoint that might be affecting why this patient isn't dealing and coping with this better? Everyone deals with pain different and adversity. Oftentimes, as I said earlier in the presentation, the subjective response to pain may have little to do with any sort of objective finding or tissue integrity. So you look at a 90-year-old versus a 15-year-old, you would think, if we're looking at structure, that 90-year-old is going to have severe pain, severe, possibly even neurologic symptoms versus a 15-year-old. But oftentimes I've seen it on the opposite end where a teenager is in severe pain, and here's a 90-year-old that has minimal symptoms and they're living their life. They just have some small issues that they want some help with. Oftentimes when someone has chronic pain, the first thing they do is they stop moving, they reduce their activity, and especially they stop having fun. This can lead to emotional issues such as depression and anxiety. Oftentimes they might start to check out on life. They might not be spending as much time with their family or friends. They might even consider stopping work as well. So we understand that when someone has pain, chronic pain, it's more of a pain issue and less of a tissue issue. Going forward, it's important to understand that pain research, it confirms that our brain can change. Our brains have the ability to change. So LeBron James wasn't born as an amazing basketball player. It took time, and his brain is a specialist at playing basketball. The same thing could be said about chronic pain too. The brain changes over time because you're a specialist at feeling pain, that now the brain has changed and rewired to where you start to sense sensations from very basic stimulation that should not be causing any sort of pain. Pain is meant as a protective mechanism, but at times, especially in the situation of chronic pain, it can be exaggerated, and it's overactive, unfortunately, and it's on high alert when it should not be on high alert. Stress and emotions can activate the danger and alarm mechanism, and pain then can be experienced. Pain is produced in the brain, so alert and danger information can enter to the brain, but the brain is the brain makes the decision if you're going to have pain or not. MRI findings are not correlated with pain severity. So again, structure doesn't necessarily equal pain severity. You can improve chronic pain with education, learning about pain, and also incorporating some sort of cognitive and behavioral interventions, which I'll talk about in a few. You can also reduce the danger alarm mechanism or reduce the amount of pain that you have by just accepting that you have pain. Stopping from or trying to stop from trying to control that type of pain, and instead you start to accept that you do have pain, and what are you going to do about it going forward. The other thing that you can do to help reduce pain is by making changes in your life, reducing stress in your life. So whether that's your job that might be really contributing to that, perhaps your marriage is contributing to that, and just trying to take actions and reasonable changes to help improve your life, reduce your stress, and likely reduce your pain along the way. So based off research, and this is what I try to incorporate at least into my PT treatments for patients that have chronic pain, is that the whole goal is to calm extrasensitive nerves. So we're trying to improve their sleep, or we want them to improve their sleep. We want them to decrease their stress. We want them to start to incorporate more physical activity, because it's well known that exercise will help the body handle stress better. And we want them to start adding some sort of enjoyment to their life as well. Treatments, There are medications out there that can turn down that volume, that volume knob, the volume control for how much you're sensing pain. Pain education, just like what you're doing here today, you're learning about pain, and you are trying to make necessary changes to reduce the amount of pain that you might experience. You're trying to change that whole danger harm mechanism. Incorporating aerobic and conditioning exercises, so biking, swimming, maybe even based off what kind of condition you are in, maybe even getting back into doing some sort of running again too. And then doing stress reduction activities. So for me personally, I'll walk the dogs outside, just anything outdoors, going hiking, anything that can help reduce your stress. And then acceptance that you have pain. Stop trying to control the pain. The more that you focus on something, such as every time I bend forward, there's a high chance I'm going to throw my back out. The more that you think about that, you're going to wire those nerves together and they're going to fire together. So when you do bend over, you're anticipating that pain, and likely you're going to create that pain. So trying to just accept that you have pain, and then working on conditioning, aerobic exercises to help reduce the amount of pain that you have. Try to reduce your stress, learn more about pain, and perhaps talk to your provider if there's any medication that they might recommend to help reduce the pain volume. So Arnold Schwarzenegger, I think, would agree with me that exercise is essential to managing chronic pain. Chronic pain is associated with chronic exposure to stress. So again, we're trying to reduce stress in our life. That can increase the amount of pain that we have if we are exposed to a lot of stress in our daily life. It's also known that when we have chronic pain, that your recovery will be delayed. So please understand, and what I try to always do in PT when patients come in is I try to let them know the first few weeks, it's going to be difficult, it's going to be painful, but you want to persevere through it. There's no harm that's occurring with what we're doing in physical therapy. What we're trying to do is just get you to move again. There's no harm with this. It's actually good for you. Unfortunately, the nerves are just so sensitive, and in that area, wherever they have pain, more than likely they have a lot more nerve pain receptors. So anytime you stimulate that area, you might start to sense more pain. But over time, that can be changed. The wiring system in our brain can change. So just understand, you want to start low and slow, and you build from there. And it's quite the trick to try to figure that out. But I think the most important thing with individuals that have chronic pain is that you have that conversation with them, that you're aware that they have pain. You're taking that all into account when you're prescribing these activities and exercises for them to do. It's recommended that you do aerobic exercises. So any activity that can get your heart rate max up to about 70%. It's been shown that when you do that, it can help reduce your pain. It can improve your fatigue, and also help with any sort of emotional issues such as anxiety and depression. It can improve your quality of life, and it can improve your fitness, among many other things too. Aerobic exercise has been found to be better and greater than doing any sort of isometric or eccentric type of exercising. And as I said earlier, graded exposure to exercise is the best thing that you can do. You're not going full out I had one patient, he decided he went from being more so a couch potato to wanting to do 100 push-ups a day. And so after 3 days, he developed severe pain in his shoulder, and then he had to eventually come to rehab. But you want to start low and slow, and you build. It's recommended every week you add about 10% to what you did the previous week to build slowly. So it's so true that exercise is medicine. Aerobic exercise, stretching, strengthening, balance exercise like Tai Chi or even yoga, core exercises, all of these help prevent pain flare-ups. And we're a proponent for exercise. All exercise is great. Any exercise that you'll do, we're happy with, within reason, of course, and it makes sense that, why you're doing that sort of exercising. It is recommended that you get 150 minutes of moderate exercise in per week. When you do exercise, you will reduce your chances for back pain by 30%. So just in your lifetime, there's an 80% chance that you will develop some sort of back pain. And you can reduce that chance of you developing back pain by 30% down to a 50-50 shot just by exercising. When you exercise, you can improve your strength and flexibility. It can improve your pain sensitivity, improves your fatigue, improves mental health, help reduce body weight, and of course, it can help prevent chronic diseases that none of us want: heart disease, diabetes, hypertension, cancer. And then this is where a little just motivation here. So with adversity, life should never be placed on hold until we find a pain cure. Unfortunately, when we have chronic pain, there is no cure for chronic pain. It's how do we manage this? And so going forward, we manage it by reducing our stress. We even might reduce our body weight as well. That's a huge factor that can help. We try to improve our sleep. We start to exercise, maybe even start talking to a pain psychologist too about your pain. It's important to understand that there are no quick fixes. Everyone wants a brace or they want a pill, but unfortunately, there's no quick fix to helping someone that has chronic pain. It's going to be a process, and you're going to have to work through some pain, at least in physical therapy, early on for a few weeks, likely. There are some miracles, I think, that have occurred in my experience as a PT. However, it's very uncommon, and normally you have to be resilient, and you have to understand that you're going to go through a little bit of pain in the process when you're trying to break this chronic pain cycle. Resilient people, they let go of what should be. I should have a perfect back. I should be out running marathons right now. And you accept who you are right now, and you make the necessary changes to help improve yourself, your family, and you just have a good quality of life. You should seek support from your friends and family. We know that a strong social support network is very important when you're managing pain. You should continue to learn more about pain. You should try to live your best life, and you need to make your well-being a priority. So try to get stress out of your life. Try to pace yourself. Limit the work stress as talked about, and try to take ownership of your actions. You do have a choice. You can't control what life throws at you, but you can control if adversity will break you. Be resilient, and please exercise. And that's it.
Great. Thanks so much, Sean. That was so appropriate and timely, I think, for a lot of the people in the exercises medicine program currently. So we will open it up to a few questions. If folks have any questions, we can put them in the chat box there to Sean. Otherwise, if you have questions on the program, you can email me. But we'll just keep things going here for a minute or two to see if any questions pop up. And if not, we'll call it a day. One thing to remind everyone as well, all of the lectures will be on our Exercises Medicine YouTube channel. So in about 3 or 4 days, this recording will be put up on that channel. So we can always go back in case you missed anything, or oh yeah, I remember Sean said something about this. Let me go back and listen to that. So I don't see any questions. So I just want to thank Sean again for taking the time out of his day and presenting a very poignant topic to this population. And, you know, I think that a lot of things that you recommended in there and touched on are things that we're trying to promote and do through Exercises Medicine. So thank you so much for your support. And if anyone has questions, please feel free to reach out to myself or Sean.
Thank you.